Hi guys, I am Dr. Akshay Sharma and I am a cardiothoracic and vascular surgeon with a rich 10-year experience in adult and pediatric cardiac science. I'll be your cardiovascular guru teaching you various concepts of cardiovascular science for your med school examinations and various postgraduate entrance examinations like USMLE and NEET. If you find this video interesting, then do like, share and subscribe the channel The Cardiovascular Guru. We will kick off the journey of Cardiovascular Guru with a very interesting topic, the Tetralogy of Fallot. Tetralogy of Fallot is a hot topic for med school examinations, whether it be graduate examinations or the postgraduate pediatric examinations. It is also a very high yield topic for the postgraduate entrance examinations like USMLE and NEET. In this video, I'll try to explain various anatomical characteristics of Tetralogy of Fallot. So guys, let's get down to some serious business and see what we have.
So let's break down the name and see what we get. Tetra. Tetra means 4. That means we are dealing with a disease that has 4 distinct lesions. So it is known as tetralogy. And now what is Fallot? Fallot term comes from the name of the physician Etienne Louis Arthur Fallot. He was a French physician who described tetralogy. He was not the first one, but he described tetralogy in a very detailed manner way back in the year 1888. So, Fallot was a physician who described tetralogy, and tetralogy means it is a combination of 4 distinct lesions. Embryologically, tetralogy is an anomaly of conotruncal development. So let's see some one-liners about tetralogy. It is commonly known as blue baby syndrome. It is the most common cyanotic congenital heart disease beyond 1 year of age. If the exam says tetralogy, then it means it is about classical tetralogy. There are few forms of complex tetralogy that can present with cyanosis before 1 year of age. So the most important thing in this is it is the most common cyanotic congenital heart disease beyond 1 year of age. That is, the patient usually presents after 1 year of age. Cyanosis is not present at birth. Again, this is the story for classical tetralogy, not for the extreme forms of tetralogy like tetralogy with pulmonary atresia. So cyanosis is not present in the patients with classical tetralogy on birth. These patients, the patients of classical tetralogy, do not have heart failure. So heart failure is unusual in patients with tetralogy of Fallot. Now we just saw that tetralogy patients do not present with cyanosis at birth. Now the question arises that which is the most common cyanotic heart disease at birth or in the first week of life. So this was beyond 1 year of life. So if a patient presents with cyanotic heart disease and the age is less than 1 week, or the baby has cyanosis at birth. So what is the most common cause? The most common cause is TGA, transposition of great arteries. So the most common cyanotic congenital heart disease beyond 1 year of age is tetralogy, and at birth or before first week of life is TGA, transposition of great arteries. So this is for the exam goers. Read the question very carefully and look for the age of the baby.
We just learned that Tetralogy of Fallot has 4 lesions. So now let's see what they are.
Now, let's see the 4 components of tetralogy. The mnemonics are written on the corners of the screen. VOVO, VVOO. You can learn them as per your convenience. So component number 1, ventricular septal defect. Simply defect in the interventricular septum. The type, size, this we will see later on. Second, obstruction of the right ventricular outflow tract. Right ventricular outflow tract is the outlet of the right ventricle from where the blood ejects into the pulmonary artery. For simplification, in some texts and books, it is written as, this component is written as pulmonary stenosis. So, for exam point of view, pulmonary stenosis in tetralogy is similar to the right ventricular outflow tract obstruction. Third, hypertrophy of the right ventricular wall. Ventricular hypertrophy, that is thickening of the RV muscle. Fourth component is the overriding of the aorta. So these are the 4 components of tetralogy. We'll revise it again. VSD, ventricular septal defect, obstruction of the right ventricular outflow tract, that is the R, right ventricular outflow tract obstruction, RVOTO, or simply pulmonary stenosis. Right ventricular hypertrophy, and the fourth one is overriding of aorta.
We will now look into the details of each lesion, the VSD, the right ventricular outflow tract obstruction, the right ventricular hypertrophy, and the overriding of aorta.
This is the gross representation of the heart. The diagram on the left side is of the normal heart. The right-sided heart is separated from the left-sided heart by septums. The atria by interatrial septum, the ventricles by interventricular septum. The pulmonary artery PA arises completely over the right ventricle, and the aorta arises completely from the left ventricle. This word completely is very important here, and we will shortly know why is it so. Now on the right side, this represents a heart with a ventricular septal defect. What is ventricular septal defect? Simply, it is a defect in the interventricular septum. For representation purpose, I have made it here, although it can be here, 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 anywhere along the interventricular septum. A VSD now is classified according to 3 characteristics. One is the size, location, and the type of VSD. So it can be a small VSD, large VSD, location, it can be here, here, anywhere according to the septum. So now we will see the characteristics of a ventricular septal defect in tetralogy of Fallot. Characteristics of the VSD in tetralogy can be remembered by the mnemonic LMP. L for large, M for malaligned, and P for perimembranous. So let's see the components individually. The size of the VSD is large. It is a large VSD. It's not a small VSD, and it is non-restrictive. Non-restrictive means there is no pressure gradient across the VSD. See, a large VSD and both the pressures are equal. So this is a non-restrictive VSD. Type, it is a malalignment VSD. The malaligned VSDs are different from the simple VSD. Now, if we recall some embryology, then we see that in the normal heart, the division of the conotruncus ends in alignment of the infundibular and the muscular septum. So let's see if this is the infundibular septum and this is the muscular septum, then these two are aligned in a single line. But in case of malaligned VSD, we can see here, this is the infundibular septum, this is the muscular septum. It should have been, the infundibular septum should have been here. So it is malaligned. This septum, part of the septum is here and this is here. So the VSD is created by the malalignment of the septum. The location is the third component. The location is perimembranous with infundibular extension. So the mnemonic is one thing to be added. In Asians, the VSD is more common type of VSD. Location of the VSD is subaortic.
Let's go through the mnemonic once again. LMP, large, malaligned and perimembranous. The VSD in tetralogy is in size very large. It is a malaligned type of VSD and the location of VSD is perimembranous. LMP. Now let's visit the next two components, right ventricular hypertrophy and right ventricular outflow tract obstruction, or which is commonly known as pulmonary stenosis.
RVH is the thickening of right ventricular muscle, be it the septum or the RV free wall. Along with this, there are multiple thickened muscular bands, and these bands tend to encroach the right ventricular outflow. Right ventricular outflow is the part of the right ventricle, the infundibulum, that is just proximal to the pulmonary artery. So these bands encroach the outflow of the right ventricle. So with this RVH and the muscle bands comes the next component of tetralogy, that is the right ventricular outflow tract obstruction. The basic idea is that the blood flow to the pulmonary circuit is decreased. Now the cause can be right at the source is the right ventricle, or it can be distally, that is in the pulmonary circuit. So in the right ventricle we saw the cause was RVH and the muscle bands. So the right ventricular causes of right ventricular outflow obstruction in tetralogy are the RVH and the multiple muscle bands. Now distally, that is in the pulmonary circuit, we have the reason can be valvular, that is the pulmonary valve per se can be defective, or annular, that means the valve is functioning absolutely fine but the annulus of the pulmonary valve is small. So if a small annulus can definitely cause obstruction to the blood flow. Or supravalvular, that means the valve is functioning fine, the annulus is fine, but the main pulmonary artery or the branch pulmonary arteries, right and the left pulmonary artery, these are small in size. A smaller artery will cause restriction or obstruction to the blood flow to the pulmonary circuit. So right ventricular outflow tract obstruction can be due to the RVH, muscle bands and the defect in the pulmonary valve and pulmonary artery anatomy.
I hope these three components are now quite clear. Now we will visit the most confusing component of the tetralogy, that is the overriding of aorta.
Figure on the left shows the normal relation of aorta and the pulmonary artery to the interventricular septum. RV ejects completely into the pulmonary artery. Left ventricle LV ejects completely and exclusively in the aorta. In cases of simple VSD, ventricoseptal defects, that those are the acyanotic ones, there is a defect here or here, anywhere across the septum, but the LV still completely ejects into the aorta. Complete ejection of LV into the aorta. Aorta is exclusively on the left ventricle. Now, what is aortic override? In the diagram, you can see right ventricle is ejecting into the pulmonary artery. Now, this is the malaligned septum. As we saw, the VSD is a malaligned VSD. So, the aorta is not completely on the left ventricle. Some part of the aorta is peeking into the right ventricle. Some part of the aorta is arising from the right ventricle, so that the right ventricle blood is going directly to the aorta, some part of the blood. So aorta sits directly over the VSD. This is the VSD. It sits directly over the VSD, so that some part of the aorta is in the right ventricle. In classical tetralogy, this some part is less than 50%. So the other spectrum of tetralogy in which the part of the aorta that overrides is greater than 50% is known as double outlet right ventricle. In this, there is greater than 50% of override. So in simple words, what is override? Some part of the aorta is in the right ventricle. Aorta sits directly on the VSD and some part of the aorta peaks into the right ventricle, so that the right ventricle, some part of the right ventricle blood goes directly into the aorta. This is what we call a aortic override.
I tried to simplify the anatomical characteristics of Tetralogy of Fallot, and I hope I had succeeded in that. My subsequent videos will be on physiological and the clinical aspects of Tetralogy of Fallot. Till then guys, stay focused and study hard.